So is it really possible to reverse diabetes? So today with us, we have Dr. Cyrus Khambatta. He's a PhD. He has written this book here with his co-author, Mastering Diabetes. And I am really impressed with the content of the book. And I personally believe that we should not have diabetes and we should be able to reverse diabetes in the at least in the early stages. I have seen Dr. Jason Fung reversing diabetes even when the people are insulin dependent. So here we have Dr. Cyrus Khambatta with us. Welcome. Tell us a little bit about yourself.
Thank you, Dr. Mobeen. I appreciate you having me here. So like you said, my name is Cyrus Khambatta, and I have a PhD in nutritional biochemistry, which means that, I've studied super nerd nutrition for the better part of, 15, almost 17 years at this point. And the reason that I got interested in nutrition in the first place was because if we travel backwards in time to the year 2002, I was actually diagnosed with 3 autoimmune conditions within a 6-month period. So the first one was Hashimoto's hypothyroidism, which is insufficient thyroid hormone production. The second one was alopecia universalis, which is basically total hair loss. I used to have eyebrows, eyelashes, hair. I used to be able to grow facial hair. I lost all of that. And then the third one was type 1 diabetes. So all 3 of these autoimmune conditions set in within a very short period of time. And I was very confused because I didn't know if it was something that I had done that had caused these problems, or if it was just sort of part of my genetic programming that it would happen at some point, and it just happened to happen, right there when I was 22. So my entire life kind of flipped upside down within a very short period of time. And I had to basically understand what it was that I could do for myself that would improve my health over the course of time, because I was in a deep, dark place. And I had followed the advice of my doctor and my nutritional team at that point, who basically told me to eat a low carbohydrate diet. And that was the advice back in 2002. And truth be told, it's 2024, and people still use a low carbohydrate diet as a primary mechanism for lowering blood glucose. So I said, you know what? Great. Sounds like a plan. What do I get to eat? And they said, well, red meat, white meat, chicken, fish, dairy products, peanut butter, turkey burgers. Just try and limit your intake of carbs that come from things like pastas and breads and cereals and rice and fruits and potatoes. And I said, okay, I mean, that doesn't sound that challenging. So I did that for the better part of the first year. And what I noticed was that even though it was supposed to keep my blood glucose controlled and actually keep my insulin use controlled, hovering somewhere about the middle 20 units per day, I found that 2 things occurred to me within the first year of living this way. Number one, my blood glucose was getting more and more uncontrollable over the course of time. It didn't matter how low my carbohydrate intake was. My glucose, I would wake up with a glucose of sometimes like 250. And then throughout the day, I would ping pong between a 250 and a 50. And then it would go up to 160. And then it would come down to a 90. And then it would go back up to a 320. And I was like, I don't understand what's going on. Like, I got an undergraduate degree in mechanical engineering. So I'm like, trained and trying to understand how to operate complex systems. And this is a system I just could not figure out. And then number 2 was that my insulin use kept on creeping up. So it started out like 25 units per day. And then it went up to 27, then 29, then 32, then 36, then 39. Then before I knew it, I was using 46. And sometimes I was using 52 units of insulin per day. But what was shocking to me was that my insulin use was creeping up even though my carbohydrate intake was low. So I knew instinctively that something was wrong with this sort of carbohydrate insulin, relationship that I had been told. And simply by suppressing my carbohydrate intake, that wasn't the only thing that was going to keep my insulin use low. I had other tools at my disposal. I just didn't know what they were. So long story short, basically a year into this process, I decided that I had to make a change because I didn't feel well. My glucose was all over the place. Insulin use was high. My energy levels were very low. I couldn't exercise as much as I wanted to. And, I grew up as an athlete. So I said, you know what, let me try something different and see if I could get any more improvements. And I ended up stumbling into eating a plant-based diet. Now, picture the scene. It's 2002. Not very many people are talking about a plant-based diet. I'm an athlete. I'm a soccer player. I'm a weightlifter. I don't want to become a vegetarian. I don't want to become a vegan. There's no way, but I was just like, oh, I guess if this is what I got to do, like I'll open my mind to it. And maybe this is something that will lead me to, safer waters. So I started eating a 100% plant-based diet, and I kind of made a quick transition. And I went into it kind of apprehensively, thinking like, oh, this is like, I'm going to lose a lot of weight, or I'm going to become really skinny, or, like this isn't going to, I don't want to eat like a woman. That's what I kept on telling myself. And what I recognized within a short period of time was that I got a tremendous amount of relief within the first month. Actually within the first week, truth be told. My glucose level my fasting glucose had fallen from an average of like 160 all the way down to less than 90 on a daily basis. So it was kind of hovering somewhere between 70 and 90 every day. In addition to that, my insulin use, this was the kicker. My insulin use went from an average of 42 units per day all the way down to an average of 24 units per day in the first week of doing this. And then over the course of the first month and second month and third month, my energy levels went up significantly. I became more hydrated. I went to the bathroom more frequently. My anxiety level about my health went down, and I started to feel like $1 million in a very short period of time. So I knew that I was onto something, but I just didn't have any science to be able to back it up. All I had was this anecdotal story of me, an N of 1. And I was like, wait a minute, like, can I get some science here? So I enrolled in PhD programs, and I went to UC Berkeley for 5 years from 2007 to 2012 so that I could really understand the mechanics and the biological mechanism of what was happening inside of this machine, and then see if I could extrapolate it to other people living with type 1 or prediabetes or type 2 and beyond. And while I was at UC Berkeley, I mean, my mind was blown, absolutely blown by how much powerful information I was able to learn. And there I uncovered that there's actually mountains of research that date back all the way to the 1930s that clearly describe what happens, or it clearly describes why blood glucose control can actually improve significantly when eating a plant-based diet. But more importantly, when eating a plant-based diet that's actually high in carbohydrate energy and low in total dietary fat. So, the focus of our conversation, for the rest of the time could be effectively like, what are the mechanics? Like, what is the biological mechanism? Because it's important. But I felt it in my body. And then when I went and got my PhD and really like uncovered all this information, I then was able to start a business called Mastering Diabetes and help over 100,000 people flat out reverse prediabetes and type 2 diabetes, and then also control insulin dependent type 1 and 1.5 with precision. And here we are today, having, hopefully made somewhat of an impact, and hopefully I can make a bigger impact over the course of time too.
That is an amazing story. So I have so many questions, because this is my passion for people not to have diabetes.
Yeah.
I feel this is an unnecessary damage that happens to the people when they get diabetic. And the traditional medicine is not looking at diabetes as something reversible. They look at it as we have the medical definition of diabetes, and that is chronic progressive disease. Correct. And eventually it's going to kill you in one way or the other. And I feel this is completely unnecessary, and we have to stop diabetes. So anyone who can talk about how to stop it in whatever is your way, I would love to listen and ask about it. Before we go further, could I just very quickly also show our audience once more your book and your site, just so that if they want to reach out to you, they can find where you are?
Good. Thank you.
So this is the book, New York Bestseller, Mastering Diabetes. And if I can just very quickly read an excerpt from here. This powerful book will revolutionize the way you think about diabetes, written by two guys at the forefront of the diabetes revolution who both have type 1 diabetes. It creates a roadmap to understand the physiology of insulin resistance and gives you tools to reverse it using powerful scientific evidence. So we are going to talk about the scientific evidence in a second. This is the book. And just very quickly, please don't mind me doing this.
Yeah.
This is Dr. Cyrus Khambatta's website. The website, the link is in the description of this video as well. It is amlagreen.com. And here there is a beautiful article that I think I would love you to read as well. I'm going to very quickly link that, post that in the comments here as well, just so for the convenience of the viewers. So with this, I want to come back to this. So what is I trained in traditional medicine. And what I learned was that pancreas would continue to become destroyed. we would keep becoming insulin resistant,
Correct.
and our diabetes would keep going up.
Correct.
The glucose glycation and the osmotic pressures would occur in various tissues that would cause tissue destruction, that would cause infections, immune issues, neurological issues, renal issues, cardiovascular issues, and eventually will succumb to this. This is what I learned, although I know differently now. Tell me, what is the mechanism when you say it can be reversed and it should be reversed? What is the mechanism that you are discussing?
Okay. So everything that you just said about your traditional education when it came to, understanding what is prediabetes and type 2 diabetes as a progressive disease that can wreak havoc on many metabolic processes, all of that is right. Diabetes is one of the worst metabolic conditions that I can think of. The one thing that is incorrect about that methodology is that prediabetes and type 2 diabetes are not reversible. Okay. What they tell you in the traditional medical system is that both of those conditions are irreversible. In fact, they tell you three things. Prediabetes is irreversible, type 2 diabetes is irreversible, and gestational diabetes that affects women is irreversible. Wrong, wrong, wrong. Okay. And I'm not a naysayer who's just trying to, stir up controversy at all. I've gone through the medical literature, I've read the entire thing, and I have a very good understanding of exactly why that's the case. The mechanism at play that creates the pre-diabetic state to begin with, okay? Pre-diabetes is the beginning of the road. Pre-diabetes can progress into type 2 diabetes. Pre-diabetes can progress into gestational diabetes in women, okay? So pre-diabetes is really where I want to focus the conversation, because if we can understand what causes that pathology and then maybe even preempt it and either get rid of it or prevent it from happening in the first place, then we're in a good place, okay? The precursor to pre-diabetes is a thing called insulin resistance. So insulin resistance is the underlying condition that sets the stage for prediabetes. Prediabetes then, if uncorrected, can then progress to type 2 diabetes, which is what happens in more than 92% of the population, the 92% of the diabetes population. And then also in the world of gestational diabetes, it can affect women by progressing from prediabetes into gestational, okay? Now, insulin resistance is really the most important topic, not only for this discussion, but also it's one of the most important conditions in the world of metabolic health. Because insulin resistance affects so many conditions. Insulin resistance sets the stage not only for all forms of blood glucose dysregulation, but in addition to that, it also sets the stage for many forms of cardiovascular disease. It can elevate your blood pressure, it can elevate your cholesterol, it can set you up for coronary artery disease. In addition to that, insulin resistance is very strongly tied to many forms of cancer. It's also strongly tied to obesity. It's also strongly tied to chronic kidney disease, peripheral neuropathy, erectile dysfunction, and even type 3 diabetes, which is considered Alzheimer's disease. So insulin resistance is important and it really matters, okay? Now, what the traditional medical world has established as the cause of insulin resistance is the overconsumption of carbohydrate, okay? So at its core, what insulin resistance really is, it's an inability of insulin to signal to the muscle and liver effectively, okay? It's the inability of insulin to efficiently signal to the muscle and to the liver that there is energy, aka glucose, amino acids, and fatty acids in the blood that can be taken up by both of those tissues. So insulin's role in this entire orchestra is to knock on the door of the liver, go knock, knock, or knock on the door of the muscle, knock, knock. There's stuff in the blood. There's glucose in the blood. There's amino acids in the blood. There's fatty acids in the blood. Do you want to take it up now? Yes or no? Under normal circumstances, a tissue that's insulin responsive or insulin sensitive will say, okay, sure, because the cell surface receptors on the outside of liver cells and muscle cells in particular, there's insulin receptors that can recognize the insulin molecule. As soon as that insulin molecule docks on the insulin receptor, it changes the motif, the actual structure of the insulin receptor, which then opens up a signaling pathway inside of the cell itself. When the signaling pathway is opened up, it elucidates so many different mechanisms that then prepare the cell for uptaking glucose in particular. So glucose is in the blood, insulin docks on the insulin receptor, The insulin receptor then basically opens the door for glucose to come in. Now, when the glucose comes in, it doesn't just rush into the cytosol or rush into the cytoplasm. It gets picked up by these things called glucose transporters. They're little spaceships that float to the surface. The glucose transporters grab the glucose and then they bring it back into the cell, and then they can do many things with that glucose. They can either oxidize, they can send it through the glycolytic pathway and then go through glycolysis and then end up either going into the mitochondria or ending up as ATP, or simultaneously, it can actually go directly into glycogen. Glycogen is a storage form of glucose, and that's basically glucose that can be reserved for future use. Okay, so that happens inside of the liver and that happens inside of the muscle tissue. And glucose is the primary fuel that insulin is most likely to stimulate the uptake of. Am I making sense up to this point?
Absolutely. I am just so enamored with your description of the mechanism. I describe these mechanisms by drawing. And I was saying how eloquent of you that without any drawing, you're creating the images for these mechanisms. So yes, thank you very much.
Amazing. Truth be told, I love to draw too. So like if I had a little pencil and paper in front of me right now, I could hopefully draw this out. But what I'll do for now is just kind of rely on my words one more time to like get people to paint the picture as well.
Perfect.
So effectively what we've described so far is when insulin docks on the insulin receptor, it can then initiate the uptake of glucose into the glucose transporter, which can then either participate directly in glycolysis or go directly into the glycogen synthesis pathway. Okay, that's what's supposed to happen. Okay. However, if insulin resistance is present inside of the liver and or inside of the muscle tissue, then what happens is that insulin comes to the surface of the cell again and goes knock, 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 and it keeps on knocking, but the cell doesn't respond. The cell doesn't respond very effectively, okay? Because most of the receptors on the cell surface have either been what's called invaginated, which means that their external cells, their external motif has been reversed and pulled into the cell, okay? So meaning that there's less insulin receptors facing the outside surface, or the insulin receptors that still are recognizing insulin on the outside surface have become relatively ineffective. And as a result of that, when insulin comes and says, knock, 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 there's stuff in the blood, do you want to take it up? The insulin receptor basically says, listen, I got too much stuff I got to deal with. There's a whole bunch of other stuff inside of me right now. I got to pay attention to this. Come back at another time. All right. So that then blocks glucose from coming into the cell. When glucose is blocked from coming into the cell, it then ends up accumulating inside of the blood, and the blood glucose concentration begins to rise over the course of time, leading to a high blood glucose value. Okay. So the entire process is dictated by whether or not insulin can effectively go knock, knock, please listen to me. Knock, knock, I'm telling you that there is something in the blood that you should suck out of circulation. If you're going to listen to me, we can participate and we can have a good time together. But if you're not going to listen to me, then you're going to end up accumulating a lot of glucose, causing a high blood glucose or a hyperglycemic state. Okay. So the next question becomes, well, why would a liver cell or why would a muscle cell not pay attention to insulin? Okay, what is the purpose? Why would a liver or muscle cell, have defective insulin receptors in the first place? Or why would the insulin receptors just not pay attention to the insulin signal? Because in that case, that causes a metabolic traffic jam that can cause a serious amount of downstream issues. And if you look into the medical literature, if you go to PubMed and you search over and over and over again, or if you pick up the copy of the Mastering Diabetes book, we have over 800 references in that book. What we clearly describe in that book is that the traditional description of insulin resistance is that it's all about carbs and sugar, right? You've probably heard this before, Dr. Bean, which is that when you consume too many carbohydrates, right? When you're eating too many carbs, whether that's breads and cereals and pastas and sodas and chips and pretzels, or whether it's fruits and potatoes and rice and beans and corn, okay? Regardless of the type of carbohydrate you eat, if you eat carbohydrate and you eat a significant amount of it, then the carbs end up creating this insulin resistance pathology, because the carbs are actually what trigger a large insulin spike. And then the large insulin spike ends up causing issues with the insulin receptor and the insulin receptor gets downregulated as a result of there just being too much insulin in the blood. Is that the story that you have been told yourself?
Yeah, so we had the PPRA gamma that was involved as well, and carbohydrates and making fatty acids, and that contributing to the resistance as well. The important thing is what medical doctors are trained in is to say these are the mechanisms that create insulin resistance, which would then over time only become further deteriorated. You cannot come back from it.
Correct.
And I think in the modern day and age with all these researches, it is, I don't want to say it, but I'm going to say it. It is kind of criminal to tell a diabetic person that this is something that you're going to live with it forever.
Correct. Because it's actually like, it's not evidence-based. It's incorrect from a biological perspective. And so to hide that truth from a patient, or to, perpetuate the previous knowledge that medical institution had developed for 50 years beyond, which is that diabetes is an irreversible condition, to continue to perpetuate that despite the fact that modern science has proven over and over again that insulin resistance is a reversible pathology, it doesn't make any sense anymore. Right? We have to get out of this old way of thinking and get into the new way of thinking.
Absolutely.
Okay.
So tell us the new way. How can we? And I also want to request one more thing.
Yeah.
As you discuss this reversibility, I would like to have your comment not only just for the pre-diabetes, but for those who are diabetic. I don't want to disappoint those who are diabetic and are looking forward to figuring out, can we be helped as well? And also type 1 as well, which you are too. So
beautiful.
Thank you.
I'm glad you brought that up, actually, because this conversation is not just focused on pre-diabetes. What I was trying to establish earlier is that pre-diabetes is almost like the first domino in like a whole chain of events, like in a very long line of dominoes, right? So if we can prevent that first domino from tipping, and then creating a collection of metabolic dysfunctions that then lead to the type 2 diabetes pathology, then we're in a good place, because we can prevent so many metabolic dysfunctions from happening in the first place, right? But the conversation about insulin resistance is really, it's about global metabolic health. It's certainly about prediabetes. It's about type 2. It's about gestational, but it is also about type 1 and 1.5 diabetes, which are autoimmune versions of type 1. I'm sorry, autoimmune versions of diabetes that are created by a dysfunctional insulin synthesis pathway inside of your beta cells. Okay, so the next logical question becomes, all right, well, again, what causes insulin resistance? Like, why is it that these cells are rejecting the signal from insulin in the first place? And again, if you read the literature, and what you'll find is that this canonical view that carbohydrates cause insulin resistance is actually an outdated philosophy that was never actually true in the first place. The true cause of insulin resistance is actually an excess consumption of dietary fat. An excess consumption of dietary fat, particularly saturated fat. Now, I know as soon as I say those words, I know what most people do is they drop their shoulders. They go, oh my God, are you going to vilify saturated fat? Are you one of those guys? Are you one of those people that thinks that saturated fat is bad for you? Right. And then there's just like this whole, collection of arguments. Right. But what I encourage all listeners to do is basically just pause with any kind of reaction that you may have to this information right now. And then just open your mind to the idea that there's an alternate explanation that actually does a very good job of explaining why insulin resistance begins in the first place. And so much of it is centered around the saturated fat molecule and what it does particularly to the insulin receptor. Okay. This is what I really want to make sure we clearly understand.
Yeah. PPAR gamma pathway is involved. Correct.
Exactly right. Okay. So the insulin receptor is a receptor that has both an internal domain and an external domain. Okay. What that means is that it's a protein that sits on the cell surface of liver cells and muscle cells, and truth be told, many other types of cells, but predominantly liver and muscles, where it's highly expressed. And the extracellular domain of that protein is responsible for recognizing insulin in the extracellular fluid. The intracellular domain is responsible for initiating a biochemical response inside of the cell. Okay. So the external domain is the one that's just like, I'm just going to put my hand up here as if it's like a catcher's mitt. And you have, white blood cells and red blood cells and, different circulating hormones, steroid hormones, peptide hormones, you name it. As soon as insulin is present inside of the extracellular fluid, insulin then docks on that insulin receptor. As soon as the insulin receptor docks and grabs that insulin molecule, what ends up happening is that there's a signal that's the actual protein itself changes its conformation. That's just a fancy way of saying that it changes its shape. So the internal domain of the insulin receptor then changes its shape. And as a result of changing its shape, it then initiates a very large cascade of signaling mechanisms inside of the cell that then enable the cell and equip the cell to be able to get glucose from the blood. It enables the cell to basically translocate those GLUT4 receptors up to the surface to capture the glucose and then to put it either into glycolysis or stick it into glycogen. So it prepares all of that machinery. It prepares the machinery that sends the GLUT4 vesicles up to the surface. It prepares the glycogen molecule and all of the enzymes required to actually synthesize and attach glucose molecules to the existing tree. It also prepares any of the insulin is the primary anabolic hormone in the body, the number one most powerful anabolic hormone in the body, which means that there's no other hormone that's more powerful at initiating fuel uptake or cell growth than insulin. Okay, it is the most powerful signal that there is. So not only is it going to prepare the cell for uptaking glucose, it's going to prepare the cell for uptaking amino acids. It's going to prepare the cell for uptaking fatty acids. It's also going to prepare the cell for making a copy of itself if it chooses to do so. So it's going to go to the DNA and it's going to start to transcribe a whole collection of genes and prepare the cell for replicating its own DNA, and then making a daughter cell that's a direct copy of it, again, if it chooses to do that. It's also going to prepare the gene transcription machinery to make new protein so that that protein can then go on to initiate any of these fuel storage mechanisms. Okay, so there's literally thousands of things that happen inside of the cell. And all of that is predicated on the insulin receptor changing shape as soon as it docks one molecule of insulin. All right, it's a really powerful mechanism. So the saturated fat molecule, what it does is the saturated fat molecule comes to the surface of the cell. And when it hits the surface of the cell, it uses what's called a fatty acid transport protein, an FATP. It uses the FATP to come through the cell surface and it comes into the cytosol. Okay. It does not require the use of insulin per se. It can, but it can get inside of the cell without the use of insulin. So it's an insulin dependent transport into the cell. Once it gets inside of the cell, the saturated fat molecule then has to decide, well, what's it gonna do? Is it gonna go and participate in beta oxidation inside of the mitochondria and get burned for ATP? Or is it gonna accumulate and get put into a lipid droplet? Okay, so what ends up happening is that as saturated fat continues to appear on the cell surface, more and more and more enter the cell. And as it enters the cell, some of it gets sent to the mitochondria, into the mitochondrial matrix, and is utilized, goes through the electron transport chain, and then is turned into ATP. But a fair amount of that cannot be burned, instantaneously, ends up accumulating in what's called a lipid droplet. And a lipid droplet is basically a temporary storage vesicle that ends up accumulating saturated fatty acids as they appear inside of the cytosol. So the lipid droplet is a storage form of fat in the same way that the glycogen molecule is the storage form of glucose. Now, here's where it gets interesting. As that lipid droplet begins to grow and get larger and larger, there's a feedback mechanism that then goes to, it goes back to the intracellular domain of the cell surface, of the insulin receptor. And then it actually prevents the insulin receptor from doing its job very effectively. So imagine what I'm trying to say is that when saturated fat begins to accumulate inside of a cell, it's a high energy signal. The cell is saying, whoa, 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 there's a lot of stuff coming in here. Hold on. Let's try and block more stuff from coming in, whatever we can. We don't want all of this energy. How do we block more stuff? Oh, I know. Let's block insulin, because insulin is the master anabolic hormone. The most effective way to block insulin is to block the insulin receptor. And that's exactly what happens. So that feeds back and it basically prevents the insulin receptor from initiating all of its biochemical machinery. And as a result of that, the insulin receptor is still there. It's still inside of the membrane, but it is less functional because the lipid droplet has now back communicated to it to basically prevent it from doing its job as effectively. So then the next time that insulin comes around and says, hey, you recognized me like 30 minutes ago. What's going on? Come on, I'm still here. I'm still here. The receptor goes, no, 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 no. Hold on. Like, there's too much stuff inside of me right now. I got all these fatty acid molecules that have accumulated. The energy charge inside of the cell has grown so significantly that I have to find a way to get rid of this energy first. And so you can really think of insulin resistance as being a self-defense mechanism. That's truly, when I first learned about this entire mechanism and it was presented to me as though it was a self-defense, epiphanies went off in my head. And I was like, oh, it makes perfect sense. Because what these cells are doing is preventing themselves from accumulating excess energy. And by effectively making the insulin receptor less effective, they're protecting themselves from further energy uptake. Is this making sense?
Absolutely. And to just add one more thing here, and then I have two questions as well.
Yeah.
Dr. Barbara E. Corky's 2011 Banting Award lecture, that also said that when we have too many food agents that are irritants for us, they cause pancreas to produce too much insulin, which then causes the cells to go into this self-defense mechanism to say it's so much energy coming in, we did not want it. And they would take down their receptors and make them less responsive. And that is how the insulin resistance also occurs. So you are absolutely correct. I have a few questions before we continue.
Please.
The question one, Jean says, is there a distinction between the effects of plant-based saturated fats like coconut oil and animal-derived saturated fats on insulin resistance?
Great question. Great question. The answer is yes and no. So saturated fat is effectively what saturated fat really is it's a linear molecule. It's basically a hydrocarbon molecule that's got somewhere between 16 and 22 carbons in it. And the term saturated effectively means that at every single occupiable position, there's a hydrogen molecule. So you have a linear chain or a chain of carbons that have completely filled parking spaces with hydrogen all over the place. Okay. So because it's a linear molecule, that is what governs its behavior. Okay. The difference between a 16 carbon saturated fat versus an 18 carbon saturated fat versus a 22 carbon saturated fat is important because the chain is getting longer, but all of them are united in the sense that they are linear molecules, and the linear molecules are used as energy storage mechanisms that can then be used to be burned or to be oxidized for ATP. Okay. Linear means that you can take energy out of it, you can break the bonds, you can get energy out of it, and then you can send it to the mitochondrial matrix and you can turn it into ATP. All right. So the question that you're bringing up is, well, the saturated fat that comes from an avocado, is that the same as the saturated fat that comes from, white chicken or from red meat? And the answer is there's going to be a slightly different distribution of, 16 carbons versus 20 carbons versus 18 carbons. But for the most part, it's the 16 carbon palmitate molecule that really causes a lot of the damage. So for the most part, you can think of saturated fat as being almost the same between these two sources. And really what it boils down to is limiting the total quantity. That's what we found to be the most effective approach. And that's what a lot of the research elucidates, which is that rather than nitpicking and saying, well, a little bit of saturated fat from here is okay, and a little bit from here is okay, your job as the end user is to limit your total saturated fat intake and bring it way down from whatever it might be. Okay, so we want to get it down to a very small quantity on a daily basis. And when you do that, that has a very profound effect at releasing the insulin receptors from being in this sort of stranglehold where the lipid droplet, which is accumulated saturated fat, has caused a reverse feedback and prevented the insulin receptor from doing its job.
Understood. Thank you very much. One more question. And before that, I have to once again admire you for the depth and the richness of discussion. And I was looking at your hand gestures and I was thinking, your body language is actually just equal to my drawings. So that is very good.
Wow, thank you. I appreciate that.
So Morrow says, I was under the understanding that the fat storage vesicles are mainly in adipose tissue.
Oh, okay. Very good question. Very good question. Okay. So we didn't talk about adipose tissue. I talked about liver and muscle mainly. So the adipose tissue is called your fat tissue. This sort of synonymous terms. Now, your adipose tissue is located all over the place. Okay. You got it. It's in your cheeks. It's in your neck. It's in your armpits. It's in your abdomen. It's in your butt. It's in your lower body. It's everywhere. Okay. It's a distributed tissue. And effectively what it is adipose tissue is a type of tissue that is made up of what are called adipocytes. And an adipocyte is a fat cell who has a very specific design. And the design of that cell is that when it recognizes fatty acids inside of the blood, and when there are, the lipoproteins that are in the blood that are the LDLs and the VLDLs and the chylomicrons that then deliver the fatty acids to those cells are primed to be able to take it up because those cells have all the right enzymatic machinery on the outside to be able to say, okay, cool, fatty acids, you're mine. And it pulls it and it grabs it, okay? So I want you to think of fat tissue or adipose tissue as being the right place to put fatty acids. It is the safe place to put fatty acids. And it may sound weird for me to say that, but in reality, from a metabolic perspective, that is the right location to put fatty acids. So another way to think about it was that if all of the fat, 100% of the fat that you put in your mouth ended up traveling down your esophagus, getting inside of your small intestine, and then into your blood and made its way into your adipose tissue. If 100% of the fat from your mouth went into your adipose tissue, type 2 diabetes probably wouldn't even be a condition that we would talk about. Okay, it wouldn't happen.
Understood.
What happens is that majority of those fatty acid molecules get inside of your adipose tissue, which is okay. But then there's a small percentage of those that end up going elsewhere. And the elsewhere that they go is your liver and muscle. And that's okay as long as the amount that goes to your liver and muscle is small, because your liver and muscle have the capacity to be able to store small amounts of fatty acids. But when the consumption of fatty acids, particularly saturated fat, is too high in your diet, then the spillover that goes outside of your adipose tissue and into your liver and muscle begins to get larger and larger and larger. And then those two tissues are the ones that are primarily affected that then initiate the self-defense mechanism that we talked about earlier.
Understood. Beautifully explained. I have more questions as well, but let me continue. So now we are at the fat of at the insulin resistance.
Yep.
Should we now figure out how can that be reversed?
Yeah.
Or is there something more in the mechanism?
Okay. So you bring up a very good point here, which is that there's a way to get out of this jail, right? How do we do it? All right. What I told you is that the overconsumption of saturated fat blocks insulin action. I'll say that one more time. The overconsumption of saturated fat blocks insulin action. Okay. That is a statement that has taken me years to develop, that is 100% justifiable by all the literature in, PubMed and beyond. Okay. So the overconsumption of saturated fat is what initiates the insulin resistance pathology. So the way to get out of this is to, number one, limit your intake of saturated fat. Okay, what we're trying to do is get to a saturated fat intake that's less than 4% of your total energy intake. If you can get to that point, you're in really, really good place. Okay, so you calculate your total energy intake in calories, and then you calculate 4%, and then you try and get your total fat intake, your total saturated fat, to be 4% or less. Okay. Another thing that you can do rather than calculating directly your saturated fat intake is to calculate your total fat intake, which is actually arguably much easier. So what we have found empirically over the course of time with working with tens of thousands of people is that if you can take your total fat intake to about 30 grams per day or less, then your saturated fat intake will be very low. And as a result of that, it will then relieve a lot of the metabolic stress that's been put on your liver and muscle. And that right there is the most powerful thing that you can do. How do you do that? Well, in my professional opinion, the most effective way to do that, the simplest thing that you can do if you're going to limit your total fat intake, is to limit your intake of animal products in general, particularly red meat, white meat, chicken, fish, and dairy products. And to try and migrate towards a diet in which you're eating a significant amount of plant material. Okay. So what I would recommend is eat 80 to 90% of your diet, maybe 80 to 100% of your diet that comes from plant-based material that's fiber rich. Fiber is incredibly important in this game. And also to not be afraid of those foods that contain a significant carbohydrate quantity, because carbohydrate is not the problem in a low-fat environment. Carbohydrate is a problem in a high-fat environment, but not in a low-fat environment. And that is the one key takeaway that most people just kind of like get a little confused about, okay? If your total fat intake is low and you maintain it in a low-fat environment at all times, then your carbohydrate tolerance will grow up and will get larger and larger and larger over the course of time. So lower fat means that you can accept and metabolize a higher quantity of carbohydrate on a daily basis. If it's the opposite and you increase your total fat intake, that will actually suppress your carbohydrate tolerance, which means you literally cannot metabolize as many grams of carbohydrate on a daily basis without your blood glucose doing weird things. Does this make sense?
It does. And the weird things will be that glucose is present everywhere now, and that glucose is going to cause osmotic pressure plus glycations, and now the tissue damage would start occurring, correct?
Yeah, so that happens if, okay, so the simplest way to think about this is if you eat carbohydrate-rich food and there is an increase of glucose in your blood, the concentration of glucose will increase in your blood following that meal. It will. There's no question about it. But if the glucose gets into your blood and is in your blood temporarily before it can find an exit into your liver or muscle within an hour of eating that meal, everything is fine. That is completely normal physiology. So in other words, if you start out with a blood glucose value of, call it 100 before a meal, you eat a carbohydrate-rich meal, your blood glucose goes from 100 to about 140, and then it comes back down to about 100 within an hour and a half or so, you got nothing to worry about. The temporary rise in blood glucose is totally normal. And then the reduction back down to its baseline level of about 100 is perfectly normal. That is good because that means that glucose got in your blood, insulin got secreted by your pancreas, insulin went, knock, knock, please take out this glucose right now. Liver and muscle said, sounds like a plan, brought the glucose in, and then it disposed of it, okay? But what you're referring to, Dr. Mobeen, which is that when there's an influx of glucose into your blood following a carbohydrate-rich meal, and then that glucose gets trapped and it doesn't go anywhere. So it stays at 140 or goes up to 160 or 180, and then it just stays and stays and stays and stays and stays and stays for 2 hours, 3 hours, 6 hours, 8 hours, and then eventually comes back down. That is a dangerous pathology. We don't want that. And that is hallmark of insulin resistance and or prediabetes or type 2. Okay, that's an elevated blood glucose value that just persists. The reason that's happening is, again, because there's a traffic jam inside of your liver and muscle. So we have to relieve the tension in your liver and muscle, which enables the glucose value to come back down.
And additionally, as there is insulin resistance, liver doesn't know that there is so much glucose sitting outside. Liver starts switching towards gluconeogenesis. So not only there's glucose coming from outside, there is glucose being produced by the body as well. So the whole thing, right?
You nailed it. Okay. You absolutely nailed it. Right. So you can think of your liver as basically your liver, when in an insulin resistant state, begins to act like a, like a toddler, right? Under normal circumstances, it's supposed to be an adult. It's supposed to listen to what everybody else is around is telling it. It's supposed to listen to all these circulating molecules, and IGF-1 said this, and insulin said this, and, estrogen said that. And it's supposed to really pay attention to all these circulating biomarkers and then adjust its behavior based off of what it detects in the blood and what it detects in the extracellular fluid. But when it develops the insulin resistance pathology, it shuts off its insulin ears, and it basically says, I don't want to talk to you. So that when insulin comes and tries to basically say, hey, knock, knock, there's stuff in the blood, do you want to take it up? It says, sorry, I'm not listening to you right now. I don't want to, just stop. And in that state, what you're saying is that the liver basically starts to act like a rogue to a certain extent. And it basically is like, you know what? Like, I'm not seeing glucose in the blood because my ears are plugged. Like, whatever, it's just not there. I can't really see anything about it. Therefore, you know what? I'm going to go manufacture my own glucose. And so it starts to break down the glycogen molecule and then manufacture its own glucose, which is called gluconeogenesis. And then it takes that glucose and guess what it does? It puts it back into the blood. So now you have even more glucose in your blood because number one, it was already trapped to begin with. And then number two, your liver is now making more of it, causing your glucose value to go even higher. Right. So that's classic liver insulin resistance. And we got to get out of that pathology. Otherwise, your glucose is never going to come back down.
Correct. So before we continue, some more questions. Jim said, what's your opinion about methane blue towards ATP production?
Methane blue towards ATP production. You know what? Truth be told, I don't know that much about methane blue, so I can't really comment on that. I'm going to have to go do some reading and come back to you on that one for sure.
Okay. And Jim, if you meant to say methylene blue, then methylene blue works on the complex 4 of the electron transport chain and provides it photons, which the complex 4 can then start working and pumping hydrogens, and that would cause ATP synthase to start working. And even if the electron transport chain is damaged, at least complex 4 and ATP synthase would start functioning and start helping to recover. But I do not know about methane blue. Next question. Nuts and Bolts says, if you are breaking a fast, is it better not to do so with anything that will produce an insulin spike because glucose will prime the insulin system?
Okay, if you are breaking a fast, is it better? Could you put that back up on the screen one time? Yeah.
If you're breaking a fast, is it better not to do so with anything that will produce an insulin spike because glucose will prime the insulin system?
Oh, interesting. Okay. So basically what you're saying is that imagine you've done an intermittent fast for some period of time. It could be 16 hours, 18 hours or longer. And then you were choosing a meal to eat in your, to break the fast in your post-fasting state. Is it smart to eat a meal that doesn't trigger an insulin response? Because if you were to do that, then that would mean that you might overproduce insulin and that you might trigger this entire system. So the truth is that so the Mastering Diabetes method basically has like 3 main components to it. Number 1 is a low-fat plant-based whole food diet, just like we discussed. Number 2 is daily movement, because daily movement is a way of mechanically stimulating your muscle tissue to uptake glucose from the blood in an insulin-independent manner. In other words, it's mechanical stimulation of your blood, of your tissue to suck glucose into your muscle tissue. And then number 3 is to perform intermittent fasting on a regular basis, because intermittent fasting is a very powerful insulin sensitizer. The beauty is that all 3 of these, independent of one another, are very powerful insulin sensitizers. So when you put one on top of the other, on top of the third, you end up with 3 insulin sensitizing mechanisms that all act together, making you extremely insulin sensitive, making it very hard for insulin resistance to persist inside of your liver and muscle. All right.
Understood.
So when you're, if you're breaking a fast, early in on the insulin resistance, as you're beginning to reverse insulin resistance in the first week or the second week or the third week or fourth week, I would agree with Nuts and Bolts that we want to try and keep the insulinogenic, property of the meal that you eat after a fast to be relatively low. Okay. So that would mean eat some non-starchy vegetables, maybe eat some beans, which are like slow acting carbohydrate. Those types of foods will be perfectly fine, because that will enable you to not necessarily cause an over secretion of insulin. But as you do this for a month, 2 months, 3 months, 4 months, what you're likely to find is exactly what, I found and what a lot of our clients have found, which is that the amount of glucose that you can ingest in that post-fasting meal is quite large. And when I say it's quite large, I mean in a per meal, you can eat upwards of, I know this is going to sound ridiculous, but you can eat upwards of 150 to 200 grams of carbohydrate in that one meal, just that one meal, without your blood glucose spiking anything beyond 140. Okay. And the number 140, I've brought this up multiple times. If you take a look at the research, and what you'll find is that non-diabetic individuals, a normal diurnal blood glucose fluctuation of non-diabetic individuals ranges from a minimum of usually about 70 to about 154 on a daily basis. Okay, so this is what's considered a normal physiological blood glucose response. And a lot of people fight me on this, and they go, no, Cyrus, a blood glucose response, anything higher than 115 is a spike. And I say, no. That's what you might believe to be the case. But if you actually look at the research, what you'll find is that the blood glucose value can go as high as 154. I'm not recommending it, but that is totally normal. So we like to cap it somewhere around 140, 145, somewhere in that ballpark. And if you can keep your blood glucose between 70 and 140 on a daily basis, you're doing just fine and you really have nothing to worry about.
Thank you. More questions before we continue. We have a gem in our hands today, you. So we're going to ask all good questions. So here is
Go for it. Rapid fire. I like it.
Yes. Jean says, does the effect of saturated fat on insulin resistance change in the presence of high physical activity or low overall calorie intake?
The answer is yes and yes. The higher your activity level and simultaneously the lower your calorie intake, two independent variables, okay, regardless of whether you're doing a lot of exercise or regardless of whether you're not eating very much food, both of them will sensitize you to insulin. Both of them will unlock that insulin resistance pathology in your liver and muscle. Both of them will cause insulin to signal more effectively inside of your liver and muscle. Both of them will cause increased glucose uptake from your blood into your liver and muscle. Both of them will cause your blood glucose to drop. So the answer is yes, 100%.
Two more questions before we continue.
Good.
Actually, three. Sorry. So Mauro says, so visceral fat is the problem?
So visceral fat is the problem. Okay, so there's two different types of fat depots. There's basically what's called visceral fat and subcutaneous fat. Okay, the visceral fat is what's surrounding your viscera. Okay, let me move the microphone. Your viscera is right here in your abdomen. Okay, so the visceral fat depot is right here in your abdomen, and then the subcutaneous fat depot is basically anything that's under the skin. Subcutaneous. Okay, so that means it could be like in your arms, it could be just like, you know, a thin layer, you know, underneath in your legs and your arms and your periphery, you name it. Okay. Research has demonstrated that the visceral depot is far more pathologically dangerous than the subcutaneous depot. So yes, we are trying to limit the amount of adipose tissue that accumulates inside of your viscera. No questions asked. The most effective way to do that, in my professional opinion, is low-fat, plant-based, whole food diet, daily movement, intermittent fasting on a regular basis. If you can execute that plan, you'll be golden. Your visceral fat depot will go down significantly. Your total body fat proportion will come down significantly, and insulin resistance will be a thing of the past.
Excellent. Next two questions, I want to combine them.
Yeah.
So they are about plant-based or not. And so here is one question. So no more bacon. And then here is the other question. Ald says, why are people reversing diabetes using high-fat diet?
Okay. I see that question on the screen. That is, in my opinion, that is the single most important question that we can ask today. Okay. Why are people reversing diabetes using a high-fat diet? That is the single most important question that I think the world is asking right now. And what I encourage you to do is recognize that eating a high-fat diet may make it'll make the biomarkers of diabetes look better on a piece of paper, but it will grow the insulin resistance pathology under the surface. What the heck do I mean by that? Here's what I mean. Imagine you started the diabetes, the type 2 diabetes, pathology, and you take a look at your fasting blood glucose is north of 125, and your A1C level is, let's call it 7.2%. Maybe your cholesterol level is also significantly elevated. Your LDL is high, your total cholesterol is high, maybe your HDL is low, and maybe your blood pressure is relatively high. Okay, so you're in an overall inflamed state. You could be living with a high CRP as well. And the collection of all these biomarkers suggests that you're not only living with type 2 diabetes, but maybe even some other cardiovascular problem. What ends up happening is that many people who eat a high-fat diet, literally the exact opposite of what I described, okay, which is either considered a ketogenic diet or a carnivorous diet, what they find is that as soon as they start eating this high-fat diet, which is very high in fat, I'm talking 80% of total calories comes from fat, and less than 10% of all calories comes from carbohydrates. So they've literally done the exact flip-flop of what I'm saying. Okay, I'm saying cap it at 30 grams of carbohydrate per day, and they're saying no, 80%, which is many hundreds of grams of fat per day. Okay, if you play that game, what you're likely to find is exactly what millions of people find, which is that the A1C level that starts out at 7.2% is going to come down. It's going to come from 7.2 to 6.5 to 6.2, and then it'll come down to a 5.4%. And you're going to be like, wow, look at that. That's great. In addition to that, what you're going to find is that your fasting blood glucose goes from 140 down to 110. And before you know it, it's 83. And you're like, wow, look at that. That's great. Then your blood pressure is going to go from, 140 over 110 all the way down to 120 over 80. You're going to be like, wow, that's fantastic. You're going to take a look at your total cholesterol and your triglyceride value. It's going to go from 270 and it's going to come all the way down to 150. And you're going to be like, wow, this is doing this wonders for my body. Even your C-reactive protein, your high sensitivity C-reactive protein, come from a 7 all the way down to a 1. And you're going to be like, wow, this is great. Okay. What you're not measuring in this scenario is one thing that is very important, which is your ability to consume carbohydrate energy. Okay, so if we go backwards and we try and figure out what is the insulin resistance pathology, what I suggested to you earlier was that the insulin resistance pathology is determined by the responsiveness of the insulin receptor itself on the cell surface of the liver and muscle. When the insulin receptor functions properly, you can put a lot of glucose into the blood and the glucose will end up inside of the tissue because the insulin receptor will be the signal, will be the escort that will say, hey, I recognize you, insulin. Please let the glucose come in. Okay. So if insulin signaling is working properly and insulin action is working properly, then great, glucose in the blood will get out of the blood very quickly and it'll get inside the liver and muscle and everything will be fine. But the people who eat a ketogenic diet or the carnivorous diet, even though they see all these biomarkers improve on a piece of paper, the minute that they put carbohydrate into their mouth, a significant amount of carbohydrate, and when I say significant, I literally mean like 30 to 50 grams of carbohydrate in one meal, which truth be told is not that much. But as soon as they do that, what do you think is going to happen? Their blood glucose is going to go up. It's not just going to go up from 100, call it from 85 to 95. It's going to go from 85 to 180, or it's going to go from 85 to 220. Okay. And this is what people who eat a high fat diet experience is that, again, the high fat intake suppresses carbohydrate tolerance significantly. And what that means is that because they're eating a high fat diet, their ability to consume and metabolize carbohydrate is so low that if they were to eat anything that's carbohydrate rich, all of a sudden you would see a blood glucose elevation. And then therefore that would require a significant amount of insulin from their endogenous pancreas. So why does this matter? This matters because the insulin resistance pathology is still present. In fact, the insulin resistance pathology grew under the influence of a high fat diet, but you're not testing it on a daily basis because you choose not to consume carbohydrate energy. Okay, so you're effectively avoiding carbohydrate. You're playing the carbohydrate avoidance game. And in the carbohydrate avoidance world, then your blood glucose stays nice and flat and everything looks good. But the second you actually test your carbohydrate your carbohydrate metabolism and your insulin signaling mechanism, you will find that it does not work. And as a result of that, that means that you are still living in an insulin resistant state. So people who are eating a high fat diet, to just sort of conclude this, end up with fantastic numbers that make it appear as though type 2 diabetes is gone because your A1C has now come below the threshold of 5.7%. And as soon as it comes below that, then the doctor takes a look at it and goes, oh, hey, look, good. Okay, you don't have diabetes anymore. It's gone. It's off your medical record. You can go away and everything's fine. But in reality, you're living in a very insulin resistant state. And the reason why that's dangerous is because over the course of time, what the literature demonstrates is two things. Number one, a low carbohydrate diet is very hard to sustain over the course of time. If you look at the literature of people who are eating low carbohydrate diets, most of the research is done within a very short time window of like 10 weeks to 6 months to a year. And beyond that, compliance is very hard because it just becomes very unpalatable and very boring and people just don't feel good. Okay. So their A1C value might come down and their triglyceride and their, total cholesterol, but over the course of time, they can't sustain that diet and then they end up flip-flopping into something different. Okay. So that's number one. And then number two, living in an insulin resistant pathology for many days to weeks to months to years is a recipe for disaster. Because again, I said at the very beginning of this talk, the higher the degree of insulin resistance inside of your liver and muscle, the higher your risk for cardiovascular abnormalities, the higher your risk for chronic kidney disease, the higher your risk for type 3 diabetes, which is Alzheimer's disease, the higher your risk for many metabolic complications down the road, 15 years, 20 years, 30 years into the future. And I don't want that for you, and I know you don't want that for you. So it may be hard to detect in the short term, but in the long term, those who are insulin resistant are at a significantly increased risk for chronic disease. And that's something that we have to talk about and we have to prepare ourselves for if you're going to choose that path.
Understood. Thank you so much. I know that we are more than an hour. I wanted to discuss, imagine if somebody like me
Yep.
would like to try, I'm an omnivore,
Yep.
would like to try to be more plant-based.
Yep.
How do we initiate?
How do you initiate? Okay, it's fantastic. So in the book, we've basically described this. We've sort of like written an entire section of the book to basically say, all right, cool. Now that you understand the theory, how can we get you to start doing this without it feeling like it's, too much change? I don't want you to get overwhelmed because it's too much, right? So effectively what we recommend doing is not trying to change your overall diet overnight and say, okay, cool, sweet. I guess that means no more chicken, no more red meat, no more dairy products, and throwing it all away and then only eating potatoes and rice and beans. Like, it's too much. Don't do that. What I would recommend is tiptoeing into this. So my recommendation is for the first 2 weeks, literally just start with changing your breakfast. That's all you do. Okay. So we give you a bunch of different breakfast recipes in there that are either fruit centric, or maybe there's oatmeal plus fruit, or maybe there's, tofu with vegetables. Okay. And what I want you to do is I want you to experiment around with carbohydrate rich, fat, low in fat, plant-based meals, and just see what you like. Do it today, do it tomorrow, and try and figure out, do I like this? Do I not like this? Is this fun? Is this not fun? Does it make me go to the bathroom? Do I get bloated? What happens, right? And stay consistent with it and do that for about a 2-week long period until you figure out your breakfast. Then, once you feel comfortable with your breakfast, now I want you to migrate to your lunch. The next 2 weeks are going to basically be, experimenting and playing with your lunch and trying to figure out, well, what do I like to eat? Do I want to eat a sandwich with chickpeas in the middle of it? Or do I want to eat some kind of baked tofu? Or do I want another smoothie, or a smoothie bowl, which is my favorite thing in the world, right? You can go sweet, you can go savory, you can make a whole bunch of different types of foods, okay? So play around with your lunch a little bit and, have some fun and make some bean meals and make some grain meals and try and figure out what do you like, what do you not like? And then get to a point where you're like, okay, cool, I got this whole lunch thing figured out now. And then 2 weeks after that, figure out the dinner, right? So that'll take a little bit of time. 6 weeks down the road, 8 weeks down the road, even if you want to move slower than that, now you finally got to a point where you're like, okay, I can do this, right? I figured out 3 or 4 meals that I like for breakfast. I got 3 or 4 for lunch, and now I have 3 or 4 for dinner. And now I feel like I'm enjoying the process. My blood glucose is coming down. My insulin requirements are coming down if you're using insulin, or maybe your metformin requirements have come down. You're starting to see the difference. You're starting to feel the difference. And what we do see with the majority of the people that we teach is that we see a lot of commonality. Number one, blood glucose comes down significantly within the first 2 to 3 weeks, very quickly. Okay. I know it may sound weird that I'm telling you to eat more carbohydrate and all of a sudden your glucose is going to come down, but trust me, it works. So number one, that's what we see. Number two, we see people with significantly more energy. Okay. A lot of people come to us and they're like, oh my God, I'm so tired. I'm so tired. I fall asleep in the middle of the day. Right. And then they start eating the way we describe. And within a short period of time, all of a sudden they're like, whoa, this feels totally different. Right. And then number three, we see people lose a lot of weight. Okay. Not everybody, but people who have a significant amount of weight to lose, anywhere from 30 pounds or more, end up going through the first month to 2 months of this process and are like, whoa, I just lost 18 pounds. How did that happen? That's pretty crazy. Right. So my suggestion to you is do it nice and slowly, do it systematically. And, Dr. Bean, how do you feel about making this transition as well? Because I know that you have tried eating some plant-based foods in the past, and you told me offline that it wasn't exactly your favorite thing to do. So if you want, I'll be your personal coach and I'll show you exactly how to make this transition happen. I think you're muted.
Thank you.
Yeah.
So thank you very much for the offer.
For
And my
sure.
experience with the plant-based diet is the following. I recognize that inflammation is the primary problem in our bodies, which then gives rise to the other chronic diseases like diabetes and other. So I had started developing, I'm 55 now. I had started developing some pains in my hands when I'll wake up. And I started saying, all right, I'm getting into the inflammatory state as well. My cells and the misfolded protein aggregates and all those inflammatory states are there. Then a friend, Margie, she invited me to plant-based diet conference. And I went there quite, thinking that it's going to be an interesting one because I do not believe in plant-based. I just believe in omnivore diet. Now over there, the whole hotel kitchen was taken over and nothing was available than the plant-based diet. So the first day I got a pizza ordered from outside. And then I said, you know what, I'm going to give it a try.
That's classic. I love it. I love that you're so
There was
honest.
no coffee. There was nothing. I got my coffee from outside, my pizza from outside. But then
Yeah.
I said, I'm here for 5 days. Why not I try it? So I tried it. And within 2 days, my hands, my pains went away. And I was walking in the lobby and doing this to my fingers because I could just move them so smoothly. Somebody walked up to me and said, you seem very nervous. You're twitching your hands. And I said, no, I'm testing my fingers. I do not have pain in them.
Mhm.
So that is my experience. So when I came back, I tried a couple of weeks of plant-based. I loved the result of it in terms of my glucose levels. However, I just could not sustain it. I just did not know what are the right things to do. If I tried to cook those vegetables, I just did not like the taste of it. So I became bloated as well. So I would love to try it because I think there is a power in there that needs to be looked at by everyone. And then they can decide that, no, it is not for me or it is for me. Just as with the omnivore or carnivore diets as well. So yes, I would love to have coaching and I would love to give it a try.
Okay, amazing. I think maybe we can somehow document this journey because I think that, if you felt such a rapid change just in the inflammation of your hands itself, there's a whole world. I like to think of a plant-based diet as the gift that keeps on giving. Because when I first tried it myself, I got a lot of rapid results within the first, month, like I had described. And then when I got to the year marker, I mean, I was a completely reborn human and I was so excited. And I went back to my original instructor. His name's Dr. Doug Graham. And I said, hey, I've been doing it for a year. And I was expecting him to be excited for me. And he goes, a year, huh? And I was like, yeah. He goes, call me when you get to 5. And I was like, what? He goes, trust me, it keeps on getting better. And then when I got to 5, I called him. He goes, call me when you get to 20. And I was like, man, this guy's ridiculous, right? Long story short is that all along the way, as inflammation gets lower and lower and lower, and as glucose starts to work more effectively, and glucose metabolism starts to work more effectively, and CRP comes down, and LDL cholesterol comes down, and blood pressure comes down, and you become more energetic, and your skin health improves, and your digestive system improves. It's just all of a sudden you're like, wow, my body feels great, and I feel young again, and I haven't felt this way in a long time.
Understood. So 2 more questions before we break.
Yep.
First is Jim saying, hasn't history taught us that low fat causes our cravings for sugar to go up?
Hasn't history taught us that low fat causes our cravings for sugar to go up? I don't know exactly what you mean by that, but there's a lot of folklore about what a low fat diet can do for you, or what a low fat diet has done. And if Jim is referring to the data that America tried a low fat diet in the 90s and it didn't work. I want to be very clear about the fact that America never went onto a low fat diet, right? When there was this like public health recommendation for America to reduce its fat content back in the 90s, the total fat content of the diet went from 39 to 37%. Okay, we're talking a 2% reduction over the course of many years. Okay, what I'm talking about is a total fat reduction. I want your total fat to be less than 15% of total calories. And Jim, I'm going to be the first person to tell you, I have the sweetest of sweetest tooths. Like, it is absurd how much sweet flavor my brain wants on a daily basis. So for me, what I found to be very effective is I got to eat a lot of sweet things. What that means is I'm eating things like mangoes and bananas and dates and papayas on a daily basis. And I eat a lot of them, and my brain is very happy with that. You would think that when you're eating a carbohydrate rich diet, that all of a sudden you would turn into like a candy monster and you turn into like a sugar monster. But what I have determined over the course of time, and I've seen this in many people, is that because your brain's preferred fuel source is glucose biochemically, that's just the way we were designed. When you feed your brain a significant amount of carbohydrate energy, specifically from whole food sources, and you get that energy early in the AM hours, it provides an ample supply of glucose to your brain early in the AM hours, which persists throughout the PM hours. And then usually by the time the middle of the afternoon and evening rolls around, when you're emotionally hungry, normally emotionally hungry for sweet foods, you just don't want them anymore because you've already gotten your fix earlier in the day. So my strong recommendation to you would be, number one, if you enjoy sweet flavors like I do, eat the sweet flavors early in the day. But number two, get them from whole sources, get them from fruits and get them from vegetables and get them from whole grains. And when you can do that, you got nothing to worry about.
Very interesting. Thank you very much for this question. And the last question, Jean says, could you discuss how your theory of saturated fat induced insulin resistance extends to the brain and its potential role in the development of type 3 diabetes or Alzheimer's disease?
For sure, for sure. Okay, I'm just going to make one correction in that from Jean. She says, can you discuss how your theory of saturated fat induced insulin resistance? Jean, it's not a theory. And I don't mean to be crude when I say that. This is not a theory. This has been proven by science over the course of the last 100 years. And so I just want to make sure that we're all on the same page here about the fact that I'm not just making this stuff up. Okay. This literally comes backed by nothing but rigorous science that's been documented for many years. And it's all inside of the medical literature. And you can fact check me all day long, every single day. And I got nothing to worry about. Okay. But the question really becomes, well, how does it affect your brain? Okay. So up until this point, we've been talking about the fact that insulin resistance can cause a reduced glucose uptake inside of your liver and muscle. But the truth be told is that there are many tissues in your body which are glucose responsive and many tissues in your body which are glucose dependent. Your brain is the single most glucose dependent organ in your body. In other words, your brain is specifically designed to uptake and run off of glucose for 99.99% of your entire waking life. And I know the people in the ketogenic community are going to lambast me for that and say, Cyrus, you're wrong. Glucose is not your brain's preferred fuel source. It's ketone bodies. That's a whole separate discussion. And trust me when I say ketone bodies are a backup fuel source. They're not the primary fuel source for your brain. And so glucose is the primary fuel source for your brain. But what's important to understand is that saturated fat can also directly communicate with saturated fat can cause cardiovascular abnormalities inside of your brain. Okay, so you have these microcapillary blood vessels, like thousands of miles of microcapillaries inside of your brain that are innervating all of the neurons that are enabling you to have cognitive power. And when you're eating a diet that's very high in saturated fat, those saturated fat molecules, they end up getting inside of the blood that then feeds those microcapillary blood vessels inside of your brain. So you can end up with cardiovascular problems inside of your brain, which then cause insulin signaling problems in your brain. Okay. Your brain requires small amounts of insulin, just tiny, tiny, tiny bits of insulin in order to function properly. When you have an insulin defect inside of your peripheral body, then it can cause problems inside of your brain. So what I'm trying to communicate is that the saturated fat doesn't just operate from here down. It can certainly impact blood flow inside of your brain, and it can certainly impact glucose metabolism inside of your brain. And when it does that for days, weeks, months, years on end, you end up with a glucose metabolism disorder inside of your brain that can then cause neurons to become dysfunctional, which can then lead to dementia and Alzheimer's 30, 40, 50 years into the future. Uh-oh, I think we're muted.
Mute again.
Yeah,
this is amazing. Thank you so much for your insights. Thank you for being here. Thank you for your time. Thank you for the education. And I see, Drbeen, I see your message here. I would reach out to them, or if you like, you can connect me to them, and I would be happy to have them. So once again, Cyrus, thank you. And before you go, I just want to show the audience here. This is the book.
Correct.
Mastering Diabetes. I am all about reversing diabetes, whichever way you can. But living with diabetes, thinking it cannot be reversed, that I think we need to correct. And I also want to quickly show you
Yes.
Cyrus's website as well. So
Okay.
this is, I have the link in the description, plus the link is in the comments as well. This is amlagreen.com, AMLAGREEN.com. And I also want to give you this quick disclaimer. I have no commissions or fees, or there is no strings attached. There is no commercials attached. There is no funds attached in all of this discussion. My hope is to just bring in things in front of you that may help some of you. Of course, there are people who are plant-based, so they are able to do it and they're happy with it. Good. Maybe there are more. And there are people who are omnivore like me, and then there are people who are carnivore as well. So whatever is the method,
Correct.
I love to bring it to them. Cyrus, thank you so much for being here.
Sure thing. Can I just drop one more thing before we leave completely?
Absolutely.
Okay. Could you share your screen one more time?
Absolutely. One
Okay.
second.
So just for full disclosure here, I am no longer with Mastering Diabetes. I was a co-creator of the program. I no longer am with that company. However, the website that you see on the screen right here, which is linked in the description below, is for a separate company. It's called Amla Green. And the reason why I want to share this information with you, and we didn't even have a chance to go into detail about this, we can do it maybe in a separate conversation, is that there's one component of a plant-based diet that has a very, very powerful inflammation reducing power, and that's called the Indian gooseberry, otherwise known as the amla berry, right? And I know, Dr. Mobeen, you used to eat amla berries when you
My
were a
mother
kid.
used to feed us amla every day. So we used to have almonds, neem, and amla every day.
Yeah, I'm so glad to hear that you have personal experience with it, because the amla berry is, in my opinion, the #1 draft pick for one of the most powerful medicinal plants that nobody knows about. Okay, it is the single most powerful anti-inflammatory food ever discovered by scientists. And this article can walk you through an understanding of what the amla berry can do and what the amla berry can do for you. Okay. So I want you guys to read this article, and I want you to go through it, and you'll see, #1, Indian gooseberries have the highest antioxidant content of any food in the world. Here's why this matters. #2, you can lower your blood glucose using a natural alternative to medication, and it has 0 side effects. You can read about the glucose reducing power of amla berries. #3, you can talk about why it's an alternative to statin medication, which is kind of powerful because there's a lot of research that shows just how powerful these berries are at reducing LDL and total cholesterol. And then in addition to that, it also helps lower blood pressure. And it also, in women, they report back that their skin and nails and hair grow stronger. And it almost seems like this miracle berry is too good to be true. So I've known about this for, the better part of 20 years. And I've been so impressed with how powerful this berry is that I felt compelled to actually turn it into a product. So at the very bottom of this, you'll see that there's this, amla green product. There's no sales pitch in any way, shape, or form. If you want to look at the product, go for it. If you don't want to look at the product, don't go for it. It's totally fine. But all I want you to know is that these amla berries are ridiculously powerful. And if you want to give yourself a little bit more fighting power in trying to reverse the insulin resistance pathology, or just flat out lower your glucose, lower your blood pressure, and lower your cholesterol, try these berries out. I think you're going to be pleasantly surprised by what you find.
So thank you very much for that. While you were saying it, Jean asked one more question. Thank you, Dr. Khambatta, for sharing with us. Enjoyed the talk. And there was another that I saw. How do I transition? It moved up, I guess. Julie said, is there a plant-based diet which is low residue to avoid bloating and constipation causing stasis?
Is there a plant-based diet which is low residue? I don't know what does low residue mean. Do you know?
No. But bloating and I thought constipation is actually not too much with the plant-based diet. Bloating can be.
It's the opposite. Yeah. So effectively, if you have digestive dysfunction, effectively what you're likely to find is that, when you start eating a plant-based diet, because it's so fiber rich, that it causes either gas, bloating, constipation, diarrhea, abdominal pain. All of that stuff can happen. That happened to me because I made a very rapid transition. So again, I recommend walking into it slowly so that you can prevent yourself from getting very bloated, from having what's called dysbiosis inside of your large intestine, or prevent yourself from having, going to the bathroom 4, 5, 6, 7, 8 times a day and ending up with like very loose stools. All right. So tiptoe. And by doing so, you're going to save yourself a lot of time and a lot of heartache in the future.
Thank you very much. And so there was one more question. Sorry, we are not leaving you alone. So Kate says, now I'm getting it. So how to make the transition? I believe we just talked about it a few minutes ago. Would you like to comment or?
Correct. So Kate, what I would recommend doing is maybe go backwards 20 minutes and listen to the discussion that we had about first figuring out your breakfast for 2 weeks, and then figuring out your lunch for 2 weeks, and then figuring out your dinner for 2 weeks, and really taking your time with the transition and having a good time playing with it, trying out some new recipes and just making it fun. Because when you make this transition and you make it too rapidly, it's overwhelming and it does not work. It does not work. So my suggestion is move slowly, be calculated, and that's the only way to actually make it stick in the long term from what I know.
Understood. So DB, I see your questions. One of your questions is more invasive and I don't want to ask such questions. The second question, why did someone I know lose their hair on plant-based diet? I'm going to pose the question, but so Cyrus, what do you think? Is there a
why did someone I know lose their hair on a plant-based diet? I don't know the answer to that. I know no specifics of the situation. My suggestion would be sometimes people equate two things that are happening simultaneously to being cause and effect, when in reality they may not be. There's a possibility that eating a plant-based diet caused your friend to lose their hair. It's possible. There's a possibility that your friend may have had, alopecia like myself, or they may have had a thyroid dysfunction, which causes them to lose hair, or any other number of, metabolic abnormalities, and that it happened to just coincide with eating a plant-based diet at the same moment in time. So it may just be an association, but not an actual causation. But again, I can't really comment on that.
Excellent. Anthony, thank you for being here. So with this, Cyrus, thank you so much for being here. Thank you for the education, for the insights, for the encouragement, for the tips how to do it and the mechanisms. I love deep and rich discussions, and you nailed it. Thank you very much.
You're the man. Thank you so much for having me here. I really appreciate it. And I hope I added up value. Your channel is one of my absolute favorite YouTube channels. And, the amount of quality information that you've provided to the world is exceptional. So thank you for the opportunity. And, you're a force for good.
Thank you very much. And cool beans with this. I'll see you next week. Bye for now.